You're all set.
Okay, and you're going to hit record?
Yeah, it already started.
Super. Well, good afternoon, everyone. My name is Carol Scott, and I am the Field Operations Manager for Advancing Excellence in America's Nursing Homes. We appreciate everybody joining us today. We've got a lot of great information to share with you regarding the Person-Centered Care Advancing Excellence goal and tools. We'll be hearing from a lot of different people today. Carmen Winston with the Centers for Medicare and Medicaid, and Kimberly and Scott from you'll have to just introduce yourself, you guys. And then Howard Dugenholz, who was the chair of the committee that worked on this goal, and then we'll be hearing from multiple nursing homes who've actually pilot tested the goal, so we're just really excited. Next slide. Next slide. Just very briefly, we want you all to know that the information that's on the Advancing Excellence website is all free. It has been put there in order to help homes develop performance improvement, and the tools and resources and everything there fits in with the QAPI requirements. We are very excited to be able to present this information to you. We also hope that you will share, as you're working on this goal or any other goal, we're hoping that you will share this information with your staff and with your families and residents. Next. And this is the website. If you're not registered on the campaign, you can go to nhqualitycampaign.org and join the campaign. We ask that you choose actually 2 goals, one clinical and one organizational. There are 9 goals to choose from. Next. And to be a part of the national effort is probably one of the main reasons to sign up. We know that it's important for homes to be able to say kind of where are we in terms of other homes on the different goals, and by all homes collecting information that's standardized, you'll be able to share this information with stakeholders and partners in your town as you work toward, inviting people to move into your home. Next slide. This is just a reminder that we have a lot of evidence-based information, that entering the data is a key part of being a participating home in the campaign, but also just ensuring that your home is following performance improvement. That really is the key and the motivation behind Advancing Excellence doing all this work. Next slide. Okay. At this point, I would like to, Adrian, could you open up the poll? Adrian? There we go. If everyone would select one of these that best describes you and the people maybe that are in the room with you, we would just like to have a sense of who's listening in on this call. So if you work in a nursing home, if you're a part of the LANE, which is the Local Area Network of Excellence, if you're with a trade association, or if you're a resident or family member. Or if none of those, then you can describe who you are. Okay. Let's see what the answers are. again, while the answers are coming up, I will just remind you that any information that's put onto the Advancing Excellence website is confidential. No one has access to the individual data that you put in. It is all confidential, like I said, and only after 10 homes in one state enter data on a particular goal will we be able to look at the aggregate numbers to see where your home is in relationship to the state and to the national. So it looks like we have about 69% of people that work in a nursing home. We've got good representation of the rest, and we actually even have some advocates, family members, and residents. Really do appreciate you all being on the call. So at this point, I'm going to turn the presentation over to Carmen Winston, who works for the Center for Medicare and Medicaid, CMS. Carmen?
Thank you, Carol. Good afternoon, everyone. I'm Carmen Winston, and I serve as the nursing home lead for the nursing home work for the Centers for Clinical Standards and Quality. And I have just lost a picture that shows me your desktop, Carol, so I just want to let you know that I cannot see the slide. But I'm going to go ahead and proceed. The first slide that you would be seeing would, in fact, let you know that the National Nursing Home Quality Care Collaborative is a collaborative of currently more than 4,500 nursing homes across the country, which represents approximately 30% of the nursing homes. And the collaborative, which commenced on February 1st of this year, works around a change package. The change package itself is a resource. Okay, thank you. I've got the slide back up now. And the change package was actually put together from site visits on 10 high-performing nursing homes. And it serves as one resource. In the package itself are strategies. And 3 strategies in particular address the topic for today's meeting. The first is Strategy 3, and it's about connecting with residents in a celebration of their life. And Strategy 6, which is about providing exceptional, compassionate clinical care that treats the whole person. Next slide, please. The collaborative wants to improve the quality of care and quality of life of residents in nursing homes across the country, and we do that by working with nursing homes. We want to focus on the successful practices of high performers because nothing is more powerful and draws us in more to believing that we can succeed than having a peer as a resource. And we utilize the findings and we share it with the other nursing homes so that they can, in fact, identify a means to improve. And at the core of it all is about building quality-centric organizations. The aim of the collaborative and its partners is to seek to ensure that every nursing home resident receives the highest quality of care, and that the collaborative is striving to instill quality and performance improvement practices, eliminate healthcare acquired conditions, and dramatically improve resident satisfaction. The collaborative ends July 31st, 2014, and we should be able to look back then on the 18 months of the collaborative and get an idea of how successful we have been. This month, we are looking forward to our second session, our learning session, for the collaborative participants on May 14th. Next slide. Strategy 3 is about connecting with residents in a celebration of their life. And in the change package are, in fact, change content. This is actual information which was gleaned from the 10 high-performing nursing homes. And as I said, it is a resource that homes can have to look at what things are possible in a topic area that they have selected. So Change Concept 3A provides examples of how to treat residents as they want to be treated, or perhaps we all know this as treat others as you would like to be treated. How to foster relationships, how to create connections with the community surrounding the home or the community that the resident formerly lived in, and how to provide compassionate end-of-life care. In fact, when we look at the strategies, distinctive nursing homes create an environment where the resident always comes first. The focus is on keeping residents active in their families' lives, in the community, and according to the residents' preferences. And at the end of life, a celebration of life honors the resident and embraces family, other residents, and staff. Some of the actual examples provided by nursing homes were that at the end of a resident's life, they let the family stay with the body of the resident as long as they like after the death occurs. And I'm sure some of you do that also. One home actually provides an option for the family to have the funeral services at the nursing home as another way of including the residents and acknowledging that this was the loved one's home also. And another action was that the nursing home provided a meal for the family during the wake. Next slide. Strategy 6 is about providing exceptional, compassionate clinical care that treats the whole person, and to, in fact, carefully build care teams and keep them together. So we're not just treating the whole person, but we're anticipating their needs. We're looking at engaging competent medical and care teams that effectively manage the residents' changing health conditions and avoids healthcare acquired conditions. We talk a lot about consistent assignment, but isn't that really how our family members know that we're okay? They know when something is not right. And most importantly, don't forget to include your medical leadership in the development of tools and communication forms when you're adding information to the medical records. And finally, have all the disciplines in the nursing home attend neighborhood meetings and encourage full participation, such as dining services and maintenance and housekeeping, and providing an opportunity to share information. Let me also repeat some of the information that Carol shared with you, which is really very important. The CMS works very hard to, in fact, have the QIOs align work which is already going on in the community. And AE is a valuable resource for tools, for information. And finally, the next slide. If indeed there is any additional information I can share with you, please feel free to contact me at the email address provided. Thank you.
Hi, I'm Howard Degenholtz from the University of Pittsburgh, and I'm here to introduce the content area of the person-centered care goal. First, I want to thank Carmen for that great lead-in, and many of the ideas and themes in the collaborative, I think, are really quite resonant with what we're doing in person-centered care. Can I have the next slide, please? What I'm showing here is just an image of what the website will look like when the materials are available on the Advancing Excellence campaign for the person-centered care goal area. And I'm not going to spend time on this. I want to first tell you, I'm going to give you a background. Can I have the next slide? And we'll show you the actual items that are going to appear on that website. This is just a list of all of the wonderful people who devoted, I think, about a year's worth of weekly meetings to develop the person-centered care goal area materials, and I won't name everybody or bore you with the list, but you can see that it represented the providers, national organizations, academia, and the whole range of clinical disciplines as well. Just a fantastic group that worked very, very hard on this. Can I have the next slide? So what is the person-centered care goal? So person-centered care, consistent with what Carmen was saying, is the idea of the care should be focused on residents as a person, and that person-centered care promotes choice, purpose, and meaning in daily life. To me, it puts everybody's focus on the individual autonomy, the personal autonomy of the resident. When care is being delivered in this way, what it means is that residents are going to be supported in achieving the level of physical, mental, and psychosocial well-being that is individually practicable. So it's not about magical thinking about everybody is going to get to go to baseball games and go to the opera, and it's about identifying who these people are, connecting them with their individuality, connecting them with their own sense of identity, and helping them find and build a daily life that allows them to enact that identity. Time for the next slide, please. So to give you a little bit of background of what we did was we started with a fairly exhaustive review of the literature in the area of quality of life and person-centered care. One of the biggest things that's out there is the artifacts of culture change. It's not spelled out, but people are probably familiar with it, and you'll find links to all the materials that we reviewed on the resources page of the website. We also covered a lot of instruments that are approaches like artifacts to defining and measuring person-centered care that can be used as ways to reorient the work of the nursing home towards these goals. The challenge that we found with these is that they're indirect. Artifacts is primarily structural aspects of the facility. The staff report measures are very good at putting a definition of person-centered care and finding out what do staff think about it and what do they perceive. But what we concluded is that the really critical thing that's missing from these materials is a way to incorporate the resident's voice into the day-to-day work of making person-centered care the business of the nursing home. We recognize that there are a lot of facilities that are already doing person-centered care, whether it's through the culture change movement, Pioneers Network, or using the artifacts tool and redirecting your work in that direction, or perhaps they've incorporated some of these concepts into staff satisfaction surveys and other materials. That's great. We don't want to take that away. But what we're offering here is a way we think to move the ball, to make the daily experience of individual residents of care responsive to residents' preferences, and to build that information into the assessment process and the care planning process. Next slide, please. So just to give you a sense of how the person-centered care goal, if it's fully enacted, is going to benefit individual residents. It's going to give them autonomy and the ability to direct their daily care. It's going to foster engagement with staff and other residents and their community of origin. It's going to allow them and enable them to live in an environment of trust and respect for them as an individual. And most importantly, it will help foster relationships with staff that will enable staff to do a better job of the daily care that they're responsible for. Knowing the residents and being able to respond to them as individuals will also help them identify and respond to clinical issues as well. Next slide, please. There are benefits to staff also. When research has found that staff members are more comfortable caring for people that they know, that when staff can form a strong partnership with residents and their families when they have that chance to get to know them. They can anticipate residents' needs when they know what residents' preferences are. We also want to reiterate that staff are highly valued in these types of organizations, and it leads to improvements in staff satisfaction when they feel that they are a valued member of the team, that staff's perceptions and understandings and what they see and do on a daily basis becomes part of the conversation with the client and the resident, and the way that their daily care is being organized and that it's reflected in the care planning process. And we also know from research in this area and other areas that retention, job satisfaction is associated with having a relationship with residents. Next slide, please. This rolls up to benefits for the facility. Nursing homes that have better quality outcomes due to the ability of staff to identify and respond to changes in the resident's condition. They can gain referrals from people who have had a good experience, and improving retention reduces reliance on temporary pool workers and improves the bottom line. Next slide, please. So, some things to tee up the next speaker to think about if you're going to approach and tackle this area. The most important thing to think about is, if you're going to take this on, who's going to be the champion for this issue in your facility? Who's on the core team that's going to really dig deep into this and figure it out and figure out how to implement it in your facility? What the Advancing Excellence campaign will provide is a list of questions to consider in examining your current processes. What the CARE tool does is that it identifies and helps you identify, is there a gap in how your facility is meeting residents' needs? And then what staff communication practices are you currently using to support person-centered care? What organizational policies and procedures are you using, and how do you change them to improve person-centered care in your facility? There are person-centered care fact sheets that can be used to communicate the goal area across your facility and to your stakeholders. The staff sheet for staff members, leaderships, and for consumers. Next slide, please. So, I'm going to turn it over to Kimberly and Scott in just a moment, and they are going to show you all of the material. They're going to show you the person-centered care goal materials, including an excellent Excel workbook that gives you step-by-step instructions to begin your quality improvement journey in this particular goal area. Thank you.
All right, thank you, Howard. This is Kimberly Van Heidsma. I am at the Polisher Research Institute, and you see in front of you here are the members of the PRI team, Polisher Research Institute team, and we are delighted to be a part of this whole process in the development of the person-centered care tool and resources. As Howard mentioned, person-centered care is really a multidimensional idea that has many, many different components. However, all the components build on knowing how an individual likes to live their daily life. And the PCC tool begins with the process of getting to know an individual resident's important preferences, and then provides information on how well we are doing as providers in meeting those preferences. The tool gives providers feedback on how well they're doing in meeting the preferences of an individual living in their community, but goes beyond that to provide information about how well they're doing in meeting preferences of groups of residents that live together in neighborhoods or households. And most importantly, this tool provides objective information about how well the community as a whole is doing in meeting the preferences of those they serve. Next slide. So today we're going to give you a brief overview of what a person-centered care concept is within this tool, and then there's no better way of showing this tool than walking through it. And we'll briefly walk through the tool so you can see the inputs and outputs. And this workbook was assembled by the combined talented efforts of Suzanne Morgenstein at the Polisher Research Institute and Adrienne Mahilek at the Colorado Foundation for Medical Care. So we'll make sure to say thank you to those two very gifted individuals. Other members of our team will present on how best to utilize the information that the tool provides. Sarah Humes, who is the Director of Therapeutic Recreation at the Abramson Center for Jewish Life, will discuss some of the logistics involved in using the tool. And Scott Crespi, Vice President of Quality Improvement at the Abramson Center, will discuss how to optimize the tool to enhance person-centered care delivery and benchmark progress. And finally, we'll hear some feedback and reflections from the communities that piloted the person-centered care tool, and the feedback from these organizations was incredibly valuable in helping us to refine the tool itself. The Person-Centered Care tool consists of 4 measures that target 2 different aspects of person-centered care. And the first aspect is the delivery of preference-congruent care, or the extent to which care is successfully tailored to fulfilling preferences important to that individual resident. Whereas the next set of 3 measures focuses on who attends the care conference meeting. So this set of measures tracks the extent to which residents, their family members, or direct care workers attend that conference. So what is preference-congruent care? Well, preference-congruent care is care that fulfills important resident preferences for both personal care and recreational activities. And the word congruent reflects the extent to which the care that is being delivered is consistent or matches the most important daily preferences expressed by that resident. The tool utilizes the 16 items from the MDS 3.0 Section F, Preferences for Customary Routine and Activities, that all of your staff collect on a regular basis. This interview can be conducted with either a resident or a family member to discover which preferences are important to the resident. And the tool only counts those preferences that are very or somewhat important, or those that the resident feels are important but can't do as a part of the quality indicator. The second half of the interview asks the residents or family members to reflect on how satisfied they are with the fulfillment of these important preferences. The satisfaction response options are mostly or completely satisfied, a little or somewhat satisfied, or not satisfied at all. The result of this is that the tool provides immediate visual feedback to caregiving staff in 3 areas: how well the care team is doing in meeting the preferences of an individual resident, how well they're doing in meeting the preferences of a household or neighborhood, and then how well the facility as a whole is doing in meeting the preferences of all of the residents under their care. So now we'll switch over to doing a live walkthrough of the tool, and we're going to start with what you would see. You have to cancel out of that. So this is a welcome screen that you would see if you downloaded this tool from Advancing Excellence. And we're going to start with going over to the List Neighborhoods tab. On this tab, you enter the month and year, followed by the names of your households or neighborhoods in your facility as you name them. If you're a small facility, you may have only 1 or 2 entries, but if you're a large community, you may have many household entries on this page. Once you enter the names of all of your households, move to click on the Record Interview tab. The Record Interview tab is the place that you go after you have collected the information from the residents in your facility. The PCC Toolkit contains easy-to-use intervention forms that you can print out for your staff to use while conducting the resident interviews, and then you take those completed interviews to this page in the Excel workbook to enter each individual resident's information. Today, we're going to enter information about Mrs. Jones. First, we enter her name into the database. It's already there. And you will then enter in the identifier field a unique identifier that you use to track the resident. And most people in this place use a room number. Then you're going to enter the resident household information from the drop-down menu. And in this case, she is living in Oak neighborhood. And the date that the interview was conducted with this resident, and that date is today's date. And then you would select the stay type from the drop-down menu, and she is in long-term care, long stay side, and we interviewed Mrs. Jones herself. Now you're ready to enter the resident responses. So the first response is in terms of choosing what clothes to wear. Mrs. Jones said that this was very important to her. Very important to her, and that she was completely satisfied with the ability to choose those clothing. So you see that a green color appears, indicating that we are fulfilling her preferences to her level of need. In the second question, we ask her how important it is for her to take care of her personal belongings. And in this case, she tells us this is somewhat important to her and that she is a little satisfied. And here we see a yellow will pop up, indicating that it's an area of concern because she is not fully satisfied in the care that she's receiving. And then finally, for the next line, choosing between a tub bath, shower, bed bath, or sponge bath, she is that's very important to her, and she is not satisfied at all. And in this case, you will get an immediate feedback again as you enter that this is now red, indicating that this is an immediate priority for care planning purposes. If we ask Mrs. Jones how important it is for her to have snacks available between meals, and she said, well, that's important, but I can't do that here, that would be entered. And what you'll see is that regardless of the answer that she provides next, this will show up as a gray, indicating that this would be of highest priority from a care planning perspective. So you would go through and you would enter all of the information for Mrs. Jones, and then you would go up to the top, back up to the top, and you see that we are now going to print this before we exit out of this slide, out of this area, and we're going to submit the data into the database. All right, so then once we've entered all of our residents' information, we're now going to go to the next tab, which is the household group information, which allows us to see the results of the interview process presented by specific households or neighborhoods. We all know that care occurs in the context of a community of individuals who live and work together every day. Individual households are like people. They each have a unique configuration of preferences and can vary in terms of their ability to meet those preferences. This tab allows you to see at a glance which preference gaps may be affecting many persons residing together in a particular household or floor. So you would start by selecting what household you would like to view first. And in this case, we'll select Spruce. And in the Spruce neighborhood, we see at a glance what Spruce is doing well and where there are opportunities for improvement. So from a doing well perspective, we're going to look for the areas of all green below as we scroll down. We scroll down and we see that having snacks available between meals is an area that is green all the way across, indicating that residents are all satisfied that the preferences are being met in this area. The same is true for being able to use your phone in private and listening to music you like. On the other side of the coin is the need for improvement. Those will be indicated by scanning for large clumps of yellow or red across this household. And here, as examples, we see that this household could focus on choosing what clothes to wear, choosing type of bath, and doing things in groups as areas for improvement. If we switch over to our other neighborhood, the Oak neighborhood, which is listed in here, we would go back up to the top, select from the drop-down menu Oak, and resubmit the data to bring up all the individuals who have data who reside in the Oak neighborhood. Here we see again that unique configuration in terms of a much different pattern of what is going well and what are areas for improvement. Here, all green areas would be choosing your own bedtime, locking things to keep them safe, and doing things in groups. Whereas need for improvement would be in choosing what clothes to wear, snacks between meals, and going outside when the weather is good. If you see blank areas within this page, it is an indication that these white areas are not important to the residents, and so therefore, again, do not count in terms of how the indicator is built. Next, we would move on to the next tab, which is Results by Preference. This presents preference congruence information for all the residents in your community at a glance. This tab gives information about how well your community is doing in fulfilling preferences for all the residents you serve by combining resident responses across short and long stay and across all households. The first column tells you how many individuals indicated that the preference was important. So in choosing what clothes to wear, 12 individuals in the facility indicated that this was an important preference, whereas 10 individuals indicated that taking care of your personal belongings was important to them. And if we go all the way to the rightmost column, the color-coded bar tells us how well the community is doing in meeting each type of preference that is asked. As a whole, this particular community is doing well in providing preference-congruent care for choosing your bedtime and using your phone in private. Opportunity for improvement remain for preferences of choosing what clothes to wear and participating in religious services or practices. Next, we'll move on to the next set of quality measures, which is a care conference attendance. The Care Conference Attendance tab allows us to record information about who attended the most recent care conference for Mrs. Jones. First, we enter Mrs. Jones' name, her stay type, which is in long stay, and the date the care conference occurred. For this care conference, Mrs. Jones was able to attend, so we select yes from the drop-down box. However, her family was not able to attend as we were unable to contact them. And finally, her direct care staff member and CNA was also not able to attend the meeting as she was not assigned to work that day. The data entered on this page will count toward the quality indicator. In the next tab, we move to optimize care planning. This represents the best practices in the industry in terms of how to optimize your care planning team and how to optimize your care planning agenda. Information entered on this tab is optional, but you can use it as a guide to bring your care planning team to the next level of expertise and quality in delivering person-centered care. Finally, we come to the tab that you will use to track how well your community is doing overall in delivering person-centered care. The Person-Centered Care Workbook automatically generates this information for you, and it generates the result for each measure by short and long stay residents in your community. For this particular community illustrated here, the preference congruence, or green, for short stay residents is 63%, whereas for long stay residents is 71%. Care conference varies by resident, staff, and family members. The short stay has the most attendance by residents, 83%, whereas long stay has the most attendance by family members or friends. You can print this page and go to the Advancing Excellence campaign website to enter and submit your data to allow you to compare your results to communities in other states and nationwide. Track your own performance from month to month to get feedback on efforts to improve your care conference attendance over time. Now we're going to return to the slideshow to continue discussing aspects of this tool, and I'm going to introduce Dr. Scott Crespi, Vice President of Quality Improvement at the Abramson Center, to talk about the pilot evaluation of the tool with 12 nursing home communities across 3 states. Scott?
Thank you, Kimberly. It was really a terrific pleasure to be involved with these nursing homes. I think they're all high performers, and they've provided some really excellent information that helped us with the development of this tool. We provided a 1-hour webinar, 4-page written evaluation of the tool we asked them to complete, and the processes surrounding it. We also interviewed each of the homes for approximately 30 minutes each, and the homes were really instrumental in working out the glitches and supporting us with great ideas about how to improve the processes. These are the homes that participated in the pilot and helped develop the materials. Several of them agreed to be on the call today to share their experiences with you. Now, there were a couple of things that we learned from the pilot homes and also from the person-centered care team. And first, there was a recommendation to have a staged implementation. Essentially to start small and grow, work out the processes for your community, and spread it out in a way that makes sense for your community. We think that once you begin to fold in the person-centered care information into your service delivery processes, you'll wonder how you ever managed without it. And as Howard mentioned earlier, assembling your core team and having a champion is critical. The pilot homes believed their most common configuration was having social services, therapeutic recreation, and nursing as a part of it. But certainly, other homes should welcome other members as well. And also, one of the key things that we learned from our pilot homes was that it was well worth it to read the implementation guide. It is long, but what we found was for the homes that didn't read it, they ended up doing way more work than they needed to do. So the guide really helps to streamline the processes. A couple other quick points. I'm going to turn it over now to Sarah Humes, our Director of Therapeutic Recreation.
Thank you, Scott. So some tips for interviewing the residents or family members. We found that some communities saw it beneficial to have the person delivering the care, for example, the CNA, to actually ask some of these questions because it gave an opportunity for them to hear directly from the resident what their preferences were. When you're doing the satisfaction portion of the interview, we suggest selecting staff who can help promote a comfortable environment for the residents so that we can allow honest and candid responses. Also, it's important to reassure the resident that there are no wrong answers. We're looking for how satisfied they are with the care they received, so no answer is incorrect. Deciding when to do the interviews, we found that for short stay residents or new admissions to long stay, to assess the preferences upon admission and assess the satisfaction about 5 to 7 days after. However, for long stay residents, we found that you can just plan the interview of both preference and satisfaction to coincide with the care conference schedules. Next slide, please. With the individual care planning, the ability to print this tool, you can bring it directly to the care conference so that you can discuss with the entire team, the resident, the family, immediately what things need improvement. Next slide, please. And this grid here is one of the examples of the items that we've included in the instruction guide. Here you see some tips for how to adapt a given preference based on different barriers that the resident may list. Our guide also includes some lists of questions to help retrieve more detailed information from the resident about their preference, a care planning decision tree, and many more things. Next slide, please. So as Kimberly was noting, when you use this tool, you can quickly see some trends that are going across a household, even your entire community. It really helps to give you the opportunity to problem solve areas for improvement. And the care planning, optimizing care planning tab can help you to set goals to increase how your care conferences are running. Next slide, please. And finally, this is a great opportunity to incorporate your results into any ongoing QAPI efforts that you may have. And it's always important to celebrate your success. It's the picture of us at the Abramson Center celebrating our success with quality improvement. I'm going to turn it back to Scott now.
Okay, thanks, Sarah. And one of the questions that we asked our pilot homes had to do with what they liked about the tool and why they thought others might be interested in using it. I'm going to kick off this first point, and then I'm going to invite one of the pilot homes, the first pilot home, to say just a bit about their experience. As we know, getting our hands around and communicating the person-centered care concept, it can be challenging and somewhat abstract. But the feedback that we got from the pilot homes is that this tool brought it down to earth and helped people understand it in a meaningful way. So now for the next point, I'd like to invite Michelle and Jessica from a home in Lafayette Hill, Pennsylvania. Are you on? Can we open the line for Michelle and Jessica?
They should be on if they unmute their line.
Okay, you may have to unmute your line, Michelle and Jessica. Okay, well, why don't we do this? Let's skip over to our final point here. Lauren, are you on the line?
Yes, I am.
Oh, great. Lauren's from Anaheim. Could you introduce yourself and the name of your facility and share your experience with us?
Hi, I am Lauren Wadsworth. I'm the Social Services Director for Mount Hope Nazarene Retirement Community in Mannheim. And my experience with this tool was nothing but positive. I absolutely loved it. And for me, the real benefit of it was looking at changing goals and preferences as the residents age and as dementia progresses or any number of factors happen. It really gives you a good look at the residents as they do get older, because we've had a number of residents come into the facility with preferring one thing, and that does change. The other thing, I did have the ability to do a couple of family interviews with this tool, and it really gave the families a good way to kind of rate our facility on how we're doing in care. And that was just really amazing for me to be able to listen to that and get that feedback from them.
Thank you so much, Lauren. Is Jessica or Michelle back? If not, we'll...
Can you hear us?
Oh, yes. Now we hear you. Could you,
we had to hang up and redial for some reason.
Could you just introduce yourself and the name of your home and share your experiences?
Sure. This is Jessica from the Hill at White Marsh in Lafayette Hill. And one of the experiences that we wanted to share was using the tool. We found it was really, it increased our communication between our staff and between our staff and residents. Traditionally, our CNAs are not involved in identifying residents' preferences. Therefore, the information wasn't always relayed back to the CNAs. So we got the CNAs involved in the interview process by asking about the preferences. And the CNAs came back and said that it was really helpful because they got to know their preferences before providing care. Overall, we just had a lot of positive feedback.
And this is Michelle from the Hill at White Marsh. We actually use the tool both in our nursing center and our assisted living area. And for both of us, we found the interview process to be a really good conversation starter in developing a more person-centered approach to care. And our residents reported feeling validated by asking questions about their preferences. They felt comforted by the interview because they felt like they were heard and we were allowing them to make choices. And we also used it to ask additional questions about resident preferences. So at the end, for example, we would say things like, okay, is there anything that I didn't cover that's really important to you, or something else you would really like us to do? So we really used it as a jumping off point.
Thank you so much, Jessica and Michelle. I'm sure so many of the homes out there are nodding their heads in terms of having similar experiences and seeing this as a terrific opportunity to involve the CNAs in understanding the residents' preferences. I'm going to switch slides here. I just want to say a bit about connecting the dots. I think this was a great point one of the homes made. So much of the information that a nursing home has is anecdotal, And pulling it all together is really challenging. But as you saw when Dr. Van Heijsma presented and when Sarah discussed, I think the homes felt that at a glance they were able to see patterns emerge and make decisions about and programmatic changes in a way that they wouldn't have been able to in the past. Now at this point, if Brad is on the line.
Hi, Scott.
Oh, hi, Brad. Brad's from Martinsburg, PA. Could you introduce yourself and your home, please?
I sure can. Yeah, my name is Brad Norris, and I'm the Director of Therapeutic Recreation at Homewood in Martinsburg, Pennsylvania. I think, Scott, the term I used was the best thing since sliced bread. It became apparent just immediately that this would be a great addition to our CQI, our QA program. The feeling was that incorporated into that, the tool would serve as a vehicle through which determinations can be made about the qualitative measures of the person-centered approach to the care that we deliver, and also how well a facility is doing from the resident's point of view. I think for a long time that's been what's lacking. I think my feeling was too often those determinations aren't made at all, or that in cases where they are made, they're made more of anecdotal spin, and it's really more from the view of the staff than it is from the resident. So I think as far as CQI and QA goes, see this as a great addition.
Thanks so much, Brad. And I know that comment about the sliced bread will be making its way throughout the country. And now I want to ask our final pilot home representative, Gwen, from Meadsville, Pennsylvania. Are you on the line?
Yes, I am.
Oh, terrific. Could you introduce yourself and share your experiences, please?
I'm Gwen Smith, the Social Services Coordinator from Westbury United Methodist Community in Meadville, Pennsylvania. And we found that the tool helped us update each person's preference as they improve or decline as to what's important at that point in their lives. And it actually made us more aware that sometimes those preferences may change daily. Our staff and residents and families are communicating more information to us when we have been stressing to them that our goal is a more person-centered care program. And it gives us the opportunity to give each resident a voice or more control of their daily care when often their health issues are out of their control. And we've actually been collaborating with our local PCU and sharing what the person's preferences are prior to their getting here so that it's a less stressful transition and it makes the new residents feel like we already know them.
Well, thank you so much, Gwen, and thank you each of the pilot home representatives. As the listeners can hear, we had some amazing feedback, and that helped us really refine and move this tool forward. Now I'd like to turn this call back to Carol.
Thank you, Scott. What you're seeing now on the screen is the information on how to register for the campaign if you have not done so. You click on the Join the Campaign or Enroll Now button, and if you have joined in the past and have lost or forgotten your password, you need to connect with your Quality Improvement Organization, or QIO, and there is a listing of those on the website if you're not familiar with who that is. But that's the best way to get a password updated. The second way is to contact the help desk for the campaign. You're going to get a much quicker, you're going to get a quick response either way, but you'll probably get a quicker one if you go to your state's QIO. Once you have logged in, you'll then have an opportunity to choose the goals, and we hope that in addition to looking at this goal, we hope that you will look at all of the goals. You will see that This information, the tools, the resources, this is not the information that was available on the campaign prior to November of last year. So if you're recalling what you saw before, it's all completely new. You are encouraged to choose a goal that's a process goal and choose a goal that is a clinical goal. We have what we call the circle of success, which is the navigation bars across the top there that's on the right side of this page, has exploring the goals, modifying resources, examining your process, improvement, leadership, monitor and sustain, and then celebrate. And that is all part of a complete performance improvement project. Next slide. Or is that the last one? Oh, okay. So under the under the improve, that's okay. You can go to it. Under the improve is where you have the actual tools that you can use. Well, in this case, is where the form is for interviewing, the interview form and the instructions that go with that. I don't suppose Adrienne Mihalik is. No, she's not on. Okay. So this is where you would get this information. Kimberly, is there anything in particular you would want to add about this page?
No, just that this is, once you've downloaded the actual Excel tool itself, this would be your next stop in terms of getting the form that you would use to actually use to interview residents or family members, and the instructions on their use.
Okay. We have about 15 minutes, and Adrienne Westcott, if you can unmute. Okay, well, if you guys can work out getting Adrienne Mihalik unmuted, we know that she'll have something she'd like to say. But in the meantime, if people have questions, you can raise your hand over on the right-hand side, and we will unmute your line. Or if you want to type a question in to the chat box. Adrienne Westcott, are there any questions that people have raised, or is anyone raising their hand?
Yes, we do have questions. So I'm ready whenever you are.
We're ready.
How does a facility obtain the tool, and at what cost?
Oh, the cost is, I won't even make a joke about it. All of this is free. So you just go to the website, you download the materials, the Excel documents are saved to your desktop. We would hope that you would register for the campaign and enter your data so that you would be able to have a standardized form that you could share with others to show how you measure with other homes. But whether you enter your data or not, we would hope that you would download the tools and begin to use them. So, Adrienne Mihalik, are you with us now?
I am with you.
Is there anything that you want to say that didn't get said before we continue with some questions?
No, I think you covered it all. Just to clarify that on your slide, that the tracking tools are under Identified Baseline, and the interview that you do before you start using the tracking tool is under Examine Process.
Okay.
All right, and I think that we have these slides available for handout, and it also shows you how to get on, register, and select your goals, and you'll see similar buttons on submitting your data when that's been collected. And when you submit data to the website, in addition to maintaining your participation, you'll be able to see a trend of your outcomes over time. And as Carol was mentioning at the beginning, as the data are accumulate, you'll also be able to see some comparative data as well, although ultimately this is each of us striving to do our personal best.
Correct. Correct. Thank you. Adrienne Westcott, what's the next question?
How does person-centered care jibe with the fiscal realities of past Medicare, Medicaid cuts and the new sequestration? How can we be expected to do more with fewer resources expected for the future?
This is Kimberly. I would say that, we were keenly aware of the pressures on nursing homes and the constant need and requirement to do more with less. The interview process itself, half of it is a part of the typical process that you would normally do because it does utilize MDS 3.0 information that is routinely collected. And the other half of the process, we found that from the pilot facilities that depending on how much time the resident continued to talk, that the interview basically took anywhere from 5 to 15 minutes in length to do. So in terms of the time that is required, we were really trying to be judicious in terms of not making an additional demand, and then hoping that, again, that the output that you receive from this tool will actually help to, of course, improve the quality of your care, but also help from an efficiency of care delivery in that you're addressing some systemic issues and some systemic problems in some of the information that is provided by the tool that will hopefully translate into better care and more efficient care.
And I think it's also important to point out that as money becomes and stays a little bit tighter, that managed care and other insurance payers are going to be looking for homes that have performance improvement as part of their plan, and that having a picture of where one home is compared to another home will be something that those managed care and other companies are going to be looking for. So there's a great benefit internally for providing data that would indicate where you are. But I think that there's going to be just a little bit of a push from outside stakeholders who are going to be saying, we want to be able to compare the oranges and the apples, and we're looking for homes that that are meeting people's wants and needs, because that's where people are going to want to move to. So I think this is one of, and also, Kimberly, I apologize, or Scott, I apologize if I missed this, but we talked about having the CNA or direct care worker do the interview. Who is it that you were suggesting does the second part of the interview? Because wasn't necessarily someone who was a direct care worker, right? So this would be maybe somebody that would be coming in that would allow the resident to be able to very freely talk about things. So this could be a volunteer or somebody else. It wouldn't necessarily have to even be a staff person, right?
Right. Carol, this is Sarah. We found kind of all of those things in our pilot, so really what was maybe best for a specific community is what they chose to do. Most importantly, asking the satisfaction, the resident needed to feel comfortable so that we would get as much of a truthful answer as we could. So that could be the direct caregiver. It could be a different shift that may be a direct caregiver but do a little bit of a different preference meeting. So we found all different things that fluctuated between places.
And this is Scott. If I could add that one of the best practices from a pilot home was that when they did include the CNAs in the satisfaction portion, it really brought the CNA and the resident much closer. And as the CNA, as our pilot home mentioned, recognized that what the residents' preferences were, and how it led to it was an icebreaker to talk about how they could better meet those preferences in the future. And I remember one of the homes said, even though the resident might have stated 3 months ago that they like showers, that doesn't mean they want to shower every day. And what they determined was that they would check in with the resident on a daily basis. I think that might have been Gwen, I'm not sure who mentioned that to me. And so what ended up happening in that conversation was they were care planned to be asked if they prefer a shower or a bath, even though they had stated a few months ago that they prefer showers.
Okay, that's perfect. Thank you. Adrian, what's the next question?
Can you speak to how much time has been invested by the pilot homes with this interview instrument? We are utilizing the Abacus interviews as well as our normal assessment questions, and I'm wondering how all these would meld together.
I'd like to make a comment about Abacus, Scott.
Sure.
So Abacus is an instrument for facilities to use to prep for the QIS survey process. Mm-hmm. And what whoever wrote the question will know is that there are quality of life items in the QIS process. So I believe that this instrument will help improve the care planning process with regards to the types of items that are being measured in the QIS process. So what Abacus is doing is allowing you to, facilitating prep for QIS. This is going to be a daily, a way to inject the care planning process with resident-specific information that will improve the care, and that should be reflected in QIS scores. So I think there's an important connection there, an important value to the additional time that might be involved using this PCC materials.
This is Kimberly. I'll speak to the issue of how much time it took for providers to do this pilot work. We didn't ask them directly in terms of minutes how much time it took them, but I will tell you that we gave them an extremely aggressive timeline to be able to respond to our request to participate in this, and that within a 2-week time period, these facilities were able to take the tool, do interviews with 10 or more residents within their homes, and turn around that data back to provide the feedback to us. So to the extent that that speaks to the ability of the ease of use of this information and the ability for homes to quickly uptake on this information, that's certainly one of the take-home messages that we got from these homes.
Okay. Next question.
what kind of computer infrastructure is required to use the PCC tool? Who does the data entry? And would that be the social services director?
Again, this is Kimberly. The tool does require 2007 Microsoft Office Excel 2007 or higher. It cannot be utilized by a lower version at this time. And in terms of who enters the data, again, we had a wide variety of solutions to that on the part of the participating homes. Virtually anyone can enter the data. It has to be in a central location. Some folks put it on a particular computer or on a network that can be accessed for larger homes from a variety of households. But the key in doing this is that the information go to the individual who is going to input it and then print it to get it back to the care planning team.
We would like to hear about how you engage CNA staff, how they are involved with the process, and how they follow through.
This is Sarah. In our own home, when we piloted this project, it was actually fairly easy to get initial involvement with the CNA. Just kind of ask them to join us in a special project, and really as soon as they were conducting interviews with residents, they found their own benefits to that conversation. So we kind of just continued to support them and praise their good efforts.
Super. The time has come for us to wave goodbye to the camera or whatever. I want to thank all of you for presenting, and I want to thank everyone for being a part of the webinar. I hope that you will go out to the Advancing Excellence website, nhqualitycampaign.org, and play around with the tools, look at the resources, get in contact with us or with your QIO if you have any questions or comments. We are very excited about adding this goal that really will get to the quality of life as well as the quality of care of the residents. We're in debt to Howard and Kimberly and Scott and the whole team for putting together this information, and we hope that, that as you guys begin using this tool, that you'll let us know what you're finding out and share your joys with us as you get in touch with your residents. So thank you, everyone. Our next webinar will be in 2 weeks on medications. Information will be sent out next week. So again, thank you all, and we'll look forward to talking with you all again. Thank you.